We're now going to be presenting to you the results of the Vision Loss Rehab Canada's study on called Living and Vision Loss in Canada, Exploring Experiences, Access, and Pathways to Service. Okay, the Vision Loss Rehab Canada study, survey of people living with vision loss or living with blindness and partial sight, was a collaboration of a number of us. I'd just like to introduce those people to you. First of all is Jennifer Urosevic, who you just heard from. Jennifer is President and CEO of Vision Loss Rehabilitation Canada. She is passionate, and as you've just heard some of her passion, but she's passionate about fostering a strong organizational culture grounded in staff well-being, service excellence, and the delivery of the highest quality programs for blind and partially sighted clients. With a 28-year commitment to client-centered care, Jennifer has led VLRC in developing integrated care models and services that empower Canadians with vision loss to live the lives they choose. And Jennifer is the driving force behind this study. Next up will be Ashley Shaw, who is Manager, Clinical Performance and Evaluation at VLRC. Ashley works to understand how effectively VLRC's services meet the needs of people who are blind or partially sighted. She translates service data, client feedback, and research into practical improvements that enhance service delivery and client experience. And thirdly is Shannon Foster. Shannon Foster is the Executive Lead Strategic Integration at VLRC, where she guides the integration of strategy across operations and key initiatives. Her work centers on collaboration, the social determinants of health, and delivering meaningful improvements to the client experience. And last on the list is me. I'm an epidemiologist and vision researcher. I've had a long career. You can see by the little amount of hair that's on my head, for those of you who are sighted. I've had a long career being associated with, initially with the ophthalmic industry and subsequently with CNIB, Blind and Low Vision New Zealand, and the Canadian Council of the Blind. And I was delighted to be invited to be part of the study. So I'll pass this on to Jen. Thanks.
Thank you. Good afternoon, everyone, and thank you for being here as we share our national report on living with vision loss, led by Vision Loss Rehabilitation Canada in partnership with Dr. Keith Gordon, who I have a long history of working together. So this is a pleasure to work with him again. This work brings forward real experiences of people across the country who generously shared how vision loss impacts their daily life, independence, employment, mobility, and emotional well-being. What we heard was powerful. Vision loss impacts far more than eyesight. It reshapes how people navigate their communities, workplaces, support systems, often requiring adaptation that is largely unseen by others. At the same time, the report highlights persistent gaps, uneven access to services, fragmented referral pathways, inconsistent availability of technology and supports. These barriers affect safety, inclusion, and long-term outcomes. But this evidence also gives us a path forward. It strengthens our programs, informs workforce planning, and fuels our advocacy for the National Eye Care Strategy, building on the momentum of Bill C-284. Most importantly, it centers the voices of those living with vision loss and challenges us to improve conditions, equity, timely rehabilitation, and habilitation services across Canada. Thank you for your commitment to this work, and I look forward to diving into the findings and exploring how we can turn this evidence into real-life actions.
Okay, we're going to do this in 3 sections. I'm going to present the quantitative results. We did the survey, we asked people a lot of questions. I'm going to show you those results. I'm going to be throwing a lot of percentages at you. Everything that's on the slides I will be speaking to, so you don't, if you can't see it, you don't need to worry about it. And then we're going to move on to some of the other findings and the implications of those findings, which Ashley and Shannon will be presenting to you. So firstly, just to talk a little bit about methodology. We conducted this survey over the period July and August of last year. We did the survey via SurveyMonkey, so it was basically an online survey, but we did give people the option that if they couldn't do or didn't want to do the survey online, we would do it on the phone, and we did a number of telephone surveys as well. In order to get people to become aware of and sign up for doing the survey, we contacted 7,410 clients from VLRC who had active profiles in the VLRC database called Health Cloud. We had assistance from 15 community organizations who shared the survey through email and newsletters. And we promoted the survey via social media to engage both clients and, importantly, non-clients. We wanted to see clients and non-clients of VLRC. We wanted to see what non-clients were experiencing and how that compared with what clients were experiencing. So we were delighted that we had we had a very robust response. We had 1,075 respondents after we had cleansed the database for people that clearly were not involved in this area, of people that were from other countries. And we found that we had respondents from all provinces. There were participants from across Canada. The most responses were from Ontario, which constituted 57%, British Columbia 21%, and Alberta about 10%. I don't think I mentioned the survey was conducted in English or French, so you had that option. The respondents broke down demographically to being about 60% were over the age of 65, 40% were of working age between the ages of 18 and 64, about 60% were female, 17.7% identified themselves as blind, 79% as partially sighted, and 3.3% as deafblind. We thought it was important to, in terms of this understanding of the whole patient, and not just looking at eyes as we were talking about this morning. People living with vision loss very often have other disabilities that they're dealing with, and when you're dealing with a person with vision loss, you need to understand the other disabilities. So we listed a whole number of disabilities and chronic conditions that people could have and asked them to check off what they had. And we found that 43% had a physical disability and 72% had a chronic disease or health condition. That means that most people have some other condition that they're dealing with in their lives. Vision loss is not the only one. About 20% of our respondents identified themselves as being racialized. 94% spoke English at home. 26% of people lived alone. 42% lived with their spouse, and 20% lived with other families. We thought it was really important to understand how many people were actually living alone, because that that gives VLRC and other service providers an indication of what kind of support they need to give to people who are living alone to assist them and to prevent them from feeling loneliness and getting depressed. Moving on from the basic demographics that we just talked about, we looked at the education of our respondents and found that the respondents were a highly educated group. 40% of respondents had a university degree, 27% had a college diploma or certificate, and 5.3% had a trade qualification. You add that all up, you've got about 72% of people with some post-high school qualification. So all of which should make them eligible for employment. But wait till you get to the employment data, you'll see how appalling employment is in spite of the fact that this is a highly educated population. People living with vision loss are living with severe financial hardship. We found that 46% of people were living below the poverty line, and 27% fell below what's called the deep income poverty threshold, which is a statistic that governments use to indicate severe financial hardship. So not only are 46% below the poverty line, 27% are below that deep poverty line. When you translate that into dollars, we found that 16% of our respondents had a gross annual income under $15,000. 39% had a gross annual income less than $25,000, and 53% earned less than $35,000 annually. So just imagine trying to live on $15,000 a year, yet 16% of our population, 1 in 6, have that kind of income, and about 40% are less than $25,000. So this is unacceptable, to use the buzzword of the last couple of years. In addition to having low gross incomes, people living with vision loss, about 10%, only 10% of people living with vision loss received employer disability benefits. 81% received no government benefits. I'll say that again, 81% of people living with vision loss are receiving no government benefits. You know, the government keeps talking about disability benefits that they're providing, but 81% of this group anyway received no government benefits of any sort. About 30% said they were eligible for the Canada Disability Benefit, but 44% said they were unsure as to whether they qualified for the Canada Disability Benefit. So as much as the federal government's talking about the Canada Disability Benefit, we've got 44% of our population who aren't even aware whether they qualify for it. So there's an issue there, one of communication, but also the other thing is these benefits people have to avail themselves of benefits that are there. We decided to look at the nature and onset of vision loss in this community. We found that 12% of people were blind from birth, 34% first experienced vision loss over the age of 65, and that's some of these diseases that Dr. Popovich and Dr. Tao were talking about this morning, and 22% first experienced vision loss between the ages of 45 and 64. 11% of our respondents described their visual impairment as mild. 47% said that their visual impairment was moderate, and 42% said it was severe. It was interesting, we decided to look at how the description of their vision impairment changed with age, and we found that moderate impairment increased as people got over the age of 55, while severe impairment decreased. So it's not that anybody's impairment gets less, but the number of people with severe impairment, the percentage of people with severe impairment was less in the older age groups. It seemed to decline. And some of that is due to the availability of these medications. The anti-VEGFs have changed things dramatically. Also, people of older age groups don't have as severe vision loss as many younger people because they have conditions like AMD that still allow you to see somewhat. Then we asked people what the primary cause of their vision loss was. We found that 24% of respondents had age-related macular degeneration, AMD. 23% had some form of retinal disease, 15% glaucoma, about 5% had diabetic retinopathy, and 4% had lost vision due to some stroke-related cause. Interestingly, 6% of people were unsure of their diagnosis. If you have vision loss, it's really important that you understand what your diagnosis is so that you can talk intelligently with your ophthalmologist. Okay, to come back to what I was talking about in terms of employment, we found that most people living with vision loss are not employed. If you look at just working age respondents, so we're not biased here by people having retired, that people of working age, we found that 38% of working age people were employed in some capacity, with 24% being employed full-time. Let me repeat that. 24% of people of working age who have high education are working full-time. That's not 20%, 24% unemployed, that's 24% employed. So this is a terrible situation, and it hasn't changed much since CNIB did its last survey in 2018. We compared the numbers, and it's very similar. We showed that employment was strongly correlated with education. Respondents with higher education levels were more likely to be employed, but that's still working off a small base. It's not, to come back to the fact we had 72% of people with some employment, that's not the numbers we're talking about. We're just showing that people that are employed, those that are employed tend to be more highly educated. We'd just come out of the COVID period where most people were working at home. We thought it was important to understand how many people are still working at home and how, as a result, how are people getting to work and issues like that. We showed that 39% of respondents work exclusively from home, 23% work either at home or at a place of work, and 38% work only at an employer's place of work. So that's changed somewhat since COVID, and we did a survey after COVID that showed some increase, but it seems like it's more and more people are going back to work. The federal government has just demanded that everybody go back to work. So, okay. When we look at working in any employment situation, it's really important to understand what people are experiencing in terms of accommodation. We asked employed people that were employed whether they needed accommodations, and we found that 71% said that they did require accommodations. And by that I mean things like screen magnification software or screen reading software. So 71% required accommodations, but 50%, that's half of all people that need accommodations, had to provide some or all of them personally. That would be like you're going to work and your boss says to you, you've got to bring your own computer. Why is it acceptable to say to people who need accommodation, I'm sorry, better bring your own JAWS or bring your own Zoom text or whatever that is. It's just not acceptable. We asked people if they had barriers to employment, and we found that we identified a number of things that could be barriers to employment, and the one that people said was the biggest barrier to employment was the employers that were unaware of or unable to provide necessary accommodations. So the fact that employers are unaware of the need for accommodation is an education thing and something that has to be gotten over. And people said that 26% of people said that inaccessible training programs was a barrier for them gaining employment. So that's employers that are giving training programs to all of their staff, but they're not accessible. So they may give you an online program and say, do it at home, and you go home and you try to get into it and you find you can't. About slightly over half, about 58% of employed respondents said that they began losing their sight while they were employed. Of those that lost their sight while they were employed, 71% remained in the same position, 13% were retrained for new roles, and 15.5% left the organization. I was a bit surprised by that myself. I thought the number who left the organization would be higher. So I guess to me, that was good news. We then asked those who had to leave their jobs because of sight loss, were they able to continue working in the same field? And we found that about 2/3 of them could continue working in the same field, with nearly half regaining employment within 6 months. For the people that were re-employed, the people who had left their organization because of their lost vision, that were then re-employed, we asked them whether, when they were re-employed, were they able to get the same level of pay that they had before they left their previous organization. And 41% said that they did return to their previous level of pay. 16% reached the previous level of pay within a year, and 25% never regained the same income that they had before they lost their vision. And we asked then the same questions about job satisfaction, and we found that 40% had returned to their previous level of job satisfaction when they were re-employed. 12% reached their previous level of job satisfaction within a year, and 18% never regained their previous level of satisfaction. We thought it was important to understand some of the issues associated with daily life and community participation. We found that when we asked questions about shopping, we found that 39.6% of respondents did their own shopping. 41% used online shopping with either home delivery or pickup or assistance from others to do pickup. So the number of people doing online shopping has increased dramatically since a survey we did during COVID. 58.7% relied entirely on someone else to shop for them. Then we asked people, did they need help to get to various appointments or work? And we found that just over half depended on friends or family to drive or guide them to appointments or work. 14.4% used taxis or similar services. 14% used public transportation, and 10% used paratransit. So that's still more than just 52%, just over half of people are still relying on others to guide them or take them somewhere. Okay, moving on to assistive technology. We thought it was important, particularly important to understand what assistive technology people were using, particularly because we've been working with the Assistive Devices Program in Ontario, and they want to know what devices people use most. And not surprisingly, we found that 65% smartphones was top of the list. 65% of people were using smartphones. Smartphones have totally changed the lives of people living with blindness or partial sight. 51% of people were using a handheld magnifier. 43% of people had a tablet. 40% had a laptop computer. 36% a desktop computer. 24% of people had screen magnification software. 18% of people had screen reading software. And 6% of people had already ventured into the new smart glasses. I thought that was quite high, but I don't know if maybe I'm not close enough to it, but I thought that was cool because to me it's all wonderful new tech. We asked people who, basically, if they weren't using assistive technologies, what barriers they were experiencing. And we found that 38% of people said they had financial constraints in acquiring assistive technology. Well, let's go back a bit. 16% of people are earning less than $15,000 a year. How do you afford to buy a smartphone if you're earning $15,000 a year? 28% of people expressed an uncertainty about which devices are needed. Well, that's an education thing we have to get over. 25% had difficulty obtaining training for their devices. 13% didn't know where to acquire the devices. And 29% experienced no barriers at all. When we looked into assistive technology, just in terms of what people are using for mobility and navigation, that's different from the others. This is just mobility. We found that 38% of people used a long white cane, 34% used a human guide, 45% of people used smartphones equipped with navigation or accessibility apps. So that's, as I said, that's different from people, 65% of people owning a smartphone for all sorts of things. 45% were using smartphones just for mobility, or for mobility and something else. And 5.3% of people used a guide dog. I think they're all in this room. One thing that was pleasing to find is that nearly all respondents, about 92%, had access to a smartphone or computer with internet and video conferencing capabilities that enable them to stay connected with family and friends. And since this was a VLRC study, we thought we would ask people what organizations they had received rehabilitation or support services from or not. We found that 74% of people had access services from CNIB, 69% from VLRC, 3.9% from Balance for Blind Adults, and 5.6% said they hadn't received services from any of the organizations listed, and we had about 7 or 8 organizations. Almost half of people who were receiving services were referred by an ophthalmologist, 22% were self-referred, and 7% were referred by a friend or relative. Okay, we asked the people who hadn't accessed rehabilitation services, why the heck not? So we found that 31% of people were unaware that such services existed. 20% were unaware how to access such services. 25% felt they didn't need such services. And 9.6% cited distance as a barrier to services. That means that none of these services were provided in the area where they lived, because they lived in some rural area. And with that, I will pass the podium over to Ashley Shaw, who's going to tell us about some of the qualitative results that came out of our study and the implications thereof.
There you go. I'll line myself up and make sure I'm
I said, by the
audible.
way, some people have difficulty accessing those websites, like the survey website, with portable devices like a cell phone or a tablet or an iPad.
Yes, that's an excellent point, and that's why, as Dr. Gordon described, we offered kind of contact information as part of our recruitment, so that folks could reach out if they needed to kind of book a time with us in order to complete the survey by phone. Also, not everyone is at the same stage, of course, in as Dr. Gordon described, in acquiring assistive technology or in their assistive technology training, or their comfort levels, and so we wanted for people to be able to participate during that period of the survey, even if they couldn't engage with the survey platform itself or didn't want to do so. So my name is Ashley Shaw, and not to fear, we will have question and answer and lots of time to ask all of us lots of things toward the end. But for the time being, I'm going to focus on how respondents to the survey described living inside the realities that Dr. Gordon has just presented to us. So in the survey, we included an open-ended question asking people to share what it's like to live with vision loss in Canada. And this was an open-ended question, so people could write whatever they wanted. Nearly 900 of the respondents took the time to answer this question. And what emerged was not an isolated set of issues. Instead, people describe a layered experience where emotional adjustment, daily functioning, mobility, technology, social participation, and systems all interact, and where gaps in one area often amplify challenges in another. At the center of these experiences is the emotional and psychological impact of vision loss. People talked about grief over lost independence, anxiety about what will happen next, fear of their vision further deteriorating, and about the frustration of a world that suddenly requires more effort for them to navigate. Importantly, these feelings are not limited to diagnosis or early adjustment, but they resurface at key points, like losing the ability to drive, navigating workplace changes, encountering new barriers online, or struggling to access services. And while many people also describe resilience and adaptation, a critical insight is this: the emotional labor that people engage in is ongoing. Coping strategies are often developed in the absence of consistent emotional or mental health support, rather than as part of an integrated care pathway. Emotional impact, in other words, is not a side issue. It sits at the center of everything else that people experience. From that emotional core moving outward, people describe how vision loss shapes daily life. Tasks that are easy to overlook, like reading mail, managing medications, cooking, or shopping, often require new strategies, tools, or assistance. Individually, each task may be manageable, but over time, their accumulation creates fatigue and frustration. Many people describe the constant need to plan ahead, double-check, and adapt, not occasionally, but every day, and that ongoing effort shapes how independent people feel and how much energy they have left for work, for relationships, and for community life. For many, a major turning point that they talked about were changes in mobility, particularly the loss of driving. Driving is more than transportation. It represents independence, spontaneity, and control. And losing it often triggers a cascade of changes, like fewer employment options, fewer social outings, delayed appointments, and increased reliance on others. Public transit and paratransit are frequently experienced as inconsistent, inaccessible, or exhausting for people to navigate. When mobility becomes uncertain, people talk about their world shrinking, not by their choice, but by necessity. Assistive technology often acts as a buffer against loss. People use technologies to help them read, navigate, communicate, and work. And when it functions well, it restores independence and confidence. At the same time, technology introduces new barriers. And so people talked about these same ones here that Dr. Gordon talked about earlier. So the cost, the lack of sufficient training, frequent changes in digital tools, and websites or platforms that were not accessible for them. Several people describe owning devices that could help them, but not receiving enough support to use the devices effectively. A key insight here is that access to the device alone does not equal access to independence. Without training, financial resources, and accessible digital environments, technology's promise remains inequitable. These functional and mobility challenges flow directly into social experiences that people describe. They describe being overlooked in public spaces, being spoken to through companions, or being misjudged based on visible markers such as using a white cane. These interactions are often subtle, but over time they accumulate. So many people describe pulling back from social activities, not because of a lack of interest, but because the participation might require too much effort, too much explanation, or too much emotional energy. Social isolation here is not incidental. It emerges from environments and interactions that are not designed with vision loss in mind. Where someone lives also strongly shapes how vision loss is experienced. Urban, rural, and remote settings offer very different levels of access to transportation, healthcare, rehabilitation, and technology. Provincial differences in programs add another layer of inconsistency. And what emerges is not just an inequality of outcomes, but an inequality in how much effort is required to live independently by these people in different settings. As we move outward into systems such as healthcare, employment, income supports, the same pattern appears. People encounter healthcare pathways that are difficult to navigate, slow to connect them with rehabilitation services, or are unclear about what support exists. Communication gaps leave many unsure what is available or when, where, and how to receive help. And employment experiences reflect similar fragmentation. People talked about losing jobs after vision loss or experiencing workplace discrimination. They describe gaps in job accommodation policies and a lack of awareness or proper training on the part of their employers. Financial pressures shape many people's daily decisions, driven by reduced income, added costs related to vision loss, such as accessible transportation, assistive devices, and medical care. Restrictive or confusing eligibility requirements for government supports compound financial struggles for people. Across systems, people do significant work simply to connect pieces that were never designed to work together. Taken together, these accounts show us that living with vision loss is a layered experience. What people consistently describe is not a single moment of impact, but a cumulative experience where small gaps in each system add up to major losses of independence over time. Emotional adjustment sits at the core, and around it are daily functioning, mobility, technology, and social participation. Beyond that are healthcare systems, employment policies, income supports, and geography and infrastructure. When systems respond to these elements separately, the burden of integration falls to the individual, often at a time when their emotional, physical, and cognitive resources are already stretched. What is striking is not a lack of resilience. People demonstrate adaptation constantly and describe it. What is striking is how much of that adaptation happens without consistent integrated support. People describe things like the need for broad policy reforms across infrastructure, provincial funding, and assistive device programs. And with that context, how lived experiences of vision loss accumulate and reinforce one another, Shannon Foster is going to walk us through some calls to action. She will focus on what people's lived experiences point to in terms of where change is most needed and how coordinated action can reduce the burden currently carried by people living with vision loss ourselves. Shannon?
Thanks, Ashley. Thank you, Ashley and Dr. Gordon, for sharing the outcome data and the powerful insights of our respondents. What becomes clear is that vision loss itself doesn't exist in isolation. It intersects with healthcare, employment, transportation, technology, housing, and social connection. For many individuals, these challenges stack on top of each other, creating barriers that affect independence, mental health, and quality of life. Our goal is not to simply describe these challenges, it is to translate them into coordinated action. We must focus on closing systemic gaps, supporting underserved communities, integrating mental health and social services, improving accessibility, and strengthening collaboration across all sectors. Together, these steps can help create a more inclusive and supportive environment for Canadians who are blind or partially sighted or deafblind. Vision loss organizations, healthcare providers, community organizations, employers, and government all have a role to play. We're going to share some key recommendations and some calls to action for all of us. And I'll start with ourselves. We'll start with the vision loss organizations. They're here in the room as well. All of our vision loss and deafblind organizations are often the first point of connection after diagnosis. They play a critical role in helping people regain independence and rebuild their confidence. So 2 priorities emerged very clearly from the survey that we conducted. 1, we must increase access to vision rehabilitation services and assistive technologies, particularly for low-income, rural, and underserved populations. Many respondents reported experiencing wait times, limited local services, or financial barriers that prevented them from accessing the tools that could dramatically improve their daily functioning. Expanding outreach, offering mobile or virtual services, and strengthening our rural programs can help close these gaps. We also need to integrate mental health and social supports into rehabilitation services. Vision loss can bring isolation, anxiety, and grief, yet emotional well-being is often treated as separate from functional rehabilitation. Embedding counseling, peer connection, and social supports into core services ensures people are supported as whole individuals and not just as clients. For community organizations, it's essential that we combat isolation and we build belonging. Survey participants repeatedly emphasized how social connection, or the lack thereof, shapes their overall well-being. So several action priorities stand out here. We need to create more local community programs that address mental health, social inclusion, and peer support. Peer groups, mentoring programs, and community gatherings provide safe spaces to share experiences, learn coping strategies, and rebuild confidence. These connections can be life-changing, especially for people newly adjusting to vision loss. Community groups need to advocate for accessible transportation. Transportation remains one of the most significant barriers to participation in work, healthcare, and community life. Community organizations are well positioned to advocate locally for reliable, affordable, and accessible transit options. And we see this in action with CNIV's advocacy work centered on safe, accessible journeys. We need more community-based assistive technology training and lending programs. Technology can unlock independence, but only when people know how to use it and can afford it. Lending libraries, hands-on training like the programs offered by CNIV Smart Life, the Neil Squire Society, and others help individuals experiment with tools before making major purchases and ensure that technology is actually usable in their daily life. We should be facilitating social inclusion initiatives. This includes accessible recreation, cultural programming, volunteer opportunities, and community events designed with vision loss and deaf-blindness in mind. These efforts reduce isolation and improve overall quality of life. The survey highlighted the real need to prioritize individuals who are most at risk for isolation, including people living alone, older adults, and those with multiple disabilities. Targeted outreach and tailored programming can ensure that these individuals are not left behind. For our healthcare providers, you shaped the journey from diagnosis outward. Participants consistently reported gaps in communication, coordination, and referral pathways. We need to improve communication with our patients. People want clear, compassionate explanations of their diagnosis, their treatment options, and available supports. Like we heard this morning, many respondents can feel overwhelmed or underinformed at critical moments. We need to take the time to explain next steps and provide those accessible materials to make a profound difference. Healthcare providers need to work on establishing coordinated care pathways between disciplines, especially for individuals with multiple disabilities or chronic conditions. Too often, care is fragmented across providers and systems. Coordinated pathways help ensure smoother transitions from eye care to rehabilitation, mental health services, and community supports. We need to align efforts to promote regular eye exams for adults between the ages of 45 and 64. Like we heard this morning, this age group often falls through current coverage gaps, yet we know that early detection is key to preventing avoidable vision loss. Promoting proactive screening can help preserve sight and reduce long-term costs to individuals and the healthcare system. Healthcare providers need to be informed about what local vision loss supports like rehab, rehabilitation, and peer support are available for their patients. Timely referrals are critical, and providers must be aware of what's available in their communities so patients are not left to navigate complex systems alone. And healthcare providers must also address the psychosocial impacts of vision loss through their integrated care. Vision loss affects identity, relationships, and mental health. And embedding mental health supports within eye care and rehabilitation acknowledges that these realities and leads to better outcomes. Employers have a very vital role to play as well. Employment is a powerful determinant of independence, dignity, and financial security. Yet many survey respondents reported job loss, underemployment, or workplace barriers following their vision loss diagnosis. Employers and companies must be conducting workplace accessibility audits and providing reasonable accommodations. This includes adaptive technology, modified workstations, accessible documents, and support for employees transitioning to new roles after vision loss. They need to offer flexible work arrangements, including remote and hybrid options. Flexibility can make the difference between staying employed and leaving the workforce altogether. Tailored schedules and remote work reduce transportation barriers and support productivity. They must equip their HR teams with training and resources around persons with vision loss and deafblindness. Human resource staff need practical guidance on disability, inclusion, adaptive technologies, financial supports, and accommodation processes. Knowledge only empowers action. Through specific training and education with their staff, they can strengthen employee understanding and attitudes towards vision loss. This includes comprehensive disability inclusion training to help dispel myths, build confidence, and foster inclusive workplace cultures. This includes education on capabilities, adaptive tools, how they work, and inclusive practices. When workplaces are inclusive by design, everyone benefits. And our governments. Government leadership, whether it be federal or provincial, is essential to creating systemic change that's needed. The survey points to several priority areas for policy and investment. We must increase funding for vision rehabilitation, assistive technologies, and user supports. Devices alone are not enough. People also need training and ongoing assistance to use them effectively. Governments also need to fund vision loss-specific mental health, social inclusion, and peer support programs. These services are not optional add-ons anymore. They are essential to well-being and community participation. We also need coordinated federal and provincial action. Canadians currently experience uneven access to care depending on where they live. Greater coordination can ensure consistent access to vision care, rehabilitation, transportation, and support services, including in rural, Indigenous, and low-income communities. Government should be providing coordinated and expanded financial assistance for assistive technologies, including smartphones and adaptive software that are now essential for daily life. We need an investment in social, demographic, and rehabilitation research to better understand the evolving needs of people living with vision loss. Provincial governments must expand coverage for eye exams for adults aged 45 to 64 and strengthen access to preventative care. We know that early detection saves sight and reduces downstream costs. Disability benefits need to be adjusted to reflect today's cost of living realities, including updating the age structures and the payment levels. And they must improve access to the disability tax credit programs by reducing administrative barriers, shortening processing times, and simplifying eligibility. We need to see strengthened policy coordination across health, employment, and social services. Siloed systems create gaps, but integrated policy creates pathways. In closing, this survey tells a powerful story. People living with vision loss are navigating interconnected challenges across healthcare, employment, transportation, technology, and social life, but it also points towards solutions. Real progress requires collaboration, and vision loss organizations, community groups, healthcare providers, employers, government, all have distinct roles and a shared responsibility. By expanding access to rehabilitation, habilitation, technology, mental health supports, workplace inclusion, and healthcare pathways, we can align policy across sectors. We can build systems that support independence, dignity, and opportunity. This is not just about accommodation, it's truly about equity. It's about ensuring that every Canadian living with vision loss or deafblindness has the tools, supports, and opportunities they need to participate fully in society and thrive. Thank you. Jen's going to give some closing remarks.
Wow, that's my first time hearing it all. I have, of course, read the report. In closing, I want to start with a little bit of gratitude. Gratitude for each and every one of you in the room and everyone online. To our presenters and researchers behind this, Dr. Keith Gordon, Shannon, and Ashley, and for the thousands of Canadians who participated in this survey. What we heard today is not abstract. It's real life. It is people navigating vision loss while trying to work, raise families, stay connected to their communities, maintaining independence in systems that are too often not designed with them in mind. This report does something incredibly important. It moves us beyond statistics and diagnosis. It grounds us in experience. It reminds us that vision loss is not just a health issue, as Shannon just pointed out. It's a system issue. It touches employment, transportation, mental health, income security, technology, and dignity. A few things that stand out clearly. We heard too often that people don't know about vision rehabilitation and habilitation exist. And I use the word habilitation, and we've mentioned it. One of the big things that stood out for me is the word rehabilitation. And I've talked to a lot of people over the last few years, and a lot of people say, I don't need rehabilitation. I've never had vision. And so we've really tried to change our language, and I challenge all of you to think about this as well. When we're talking about vision rehabilitation, we need to also talk about habilitation. We heard that assistive technology is transformational, but often not affordable or unsupported. We heard that people want to work and could work with the right accommodations and pathways. We heard very powerfully about the emotional weight of vision loss, the isolation, the grief, and the resilience that coexists with it. So the question for us now is not what we learned. The real question is, what will we do now that we've learned this? At Vision Loss Rehabilitation Canada, this report directly informs how we will move forward because it aligns with the core values in our strategic plan, Aim Higher, Reach Further. Aim higher means that we're going to challenge ourselves to do better than just incremental changes. This data is already starting to shape how we think about earlier interventions, stronger referral pathways, and more integrated care. We know we need to meet people sooner after diagnosis. We know we need to work more closely with the eye care professionals so that rehabilitation and habilitation is not an afterthought, but it's a standard part of the healthcare continuum. This also means integrating what this report tells us about mental health, social isolation, and independence. Rehabilitation and habilitation is not just a skills-based area, it is a human-centered. We heard that this morning as well with some of the patient panelists, how important that human and looking at the whole person. That really stuck with me also from this morning. This also reinforces our commitment to holistic patient-centered care. Reaching further means extending access geographically and equitably. The report highlights stark differences in the regions and barriers that often face people in rural, remote, and underserved communities. It challenges us to expand how we deliver services, how we use technology, and how we partner across sectors to reach people where they are at, not where systems are most convenient. It also means that using this evidence beyond our own organization. This report strengthens advocacy with government. It supports national conversations about eye care, rehabilitation, habilitation, income support, assistive technology funding. It gives us credible, lived experience data that's to push for coordinated policies and sustainable funding models. And importantly, it gives us shared evidence base to work together with healthcare providers, employers, community organizations, and policymakers to design solutions that inform by real lives, not just assumptions. I also want to acknowledge something very hopeful. Despite the barriers highlighted today, this report is full of resilience. People are adapting. They are learning new skills. They are finding new ways to be engaged. And when the right supports are in place, rehabilitation, habilitation, technology, accommodations, the impact is profound. That's why this work matters. So as we leave here today, I invite all of you to carry 3 commitments forward. First, listen differently. Continuing centering lived experience in how we design programs and policies. Second, act collaboratively. No single organization or sector can solve this alone. And third, be bold. Use this evidence to aim higher and reach further in your own work, more than we've ever done that before. On behalf of Vision Loss Rehabilitation Canada, I thank you for engaging in our conversation this afternoon. And this is not the end of our report. This really is the beginning about how we turn these insights now into action. And I think now we're going to open it up for questions.
The first question is, with over half of respondents living below the poverty line and 44% are unsure about Canada Disability Benefit eligibility, what specific policy change does the panel see as most urgent to address this financial hardship and its ripple effects on independence?
Anybody want to take that?
I can start as I lose track of microphones. So one thing that I want to point out is there is a whole kind of patchwork quilt of disability benefits. There's the new kind of Canada Disability Benefit. There's federal and provincial tax credits. There are also disability support programs and kind of provincial social assistance programs based on financial means testing as well as disability status. And what doesn't support people who are already living, in poverty is when programs respond to someone, qualifying for multiple benefits by clawing back support. So we know this is something that has emerged from data. We know that not all regions are committed to maintaining support when someone receives additional benefits at the federal level. And so I just want to take the opportunity, since the question is there, to call that out as a problem when we're already dealing with, with folks living in severe poverty.
Okay, thanks. I will move on to the next question. Second one is, emotional distress and social isolation affect nearly half of respondents. How can mental health supports be more systematically integrated into vision rehabilitation services? What models have shown promise?
I can speak again, and then others can jump in if they have thoughts. I think one of the key pieces is around really establishing for people from the point of diagnosis and then through other transition points that they reach. So even if you think of a child who was diagnosed very young, they're experiencing transition points when they go through school transitions, transition to adulthood, things like that. For adults who lose their vision, or adolescents or older adults, all these different points, such as, acquiring a diagnosis, needing, to transition to audiobooks instead of reading, losing an ability to drive, all these different transition points may require, and they may affect different people differently, and they may require supports. And so my dream, if I had one, would be an integrated care model where people have, when they need it, the psychosocial, the mental health frameworks in place to support them as they reach different transitions in their journey. And a key one would be, establishing when they need some support, when they maybe need some additional skill building and strategies, when they might be ready to engage in habilitation or rehabilitation, or to re-engage if it's been a while since they've had some support and maybe their vision has changed. A framework that's responsive and coordinated with the person's healthcare and diagnosis and treatment, but also their education, their employment, and their rehabilitation journey.
And I'll just maybe add a little bit to that as well. We do provide some mental health support. We have programming within our rehabilitation programs, of which we're expanding into a national framework for all of our services. But we also, because of our connection with CNIB and the peer support programs that come out of their work, we are able to do some cross-referral in those particular cases as well. I think what's crucial here is the continuity of mental health support that need to happen from the moment of diagnosis through to their referral to us. And establishing that type of support program really needs to come from federal and provincial funding in terms of how many of those sessions can be covered under that type of a funding model. Not everybody has access to extended health benefits that might support part of their mental health journey. We can only do so much, and they do need time and access to that type of care outside of their work with us as well.
Okay, thanks. It just occurred to me before we move on to the other questions. First of all, there might be questions in the audience, but secondly, I'd like to sort of open up some of the comments particularly to other organizations. And we didn't introduce here today. I'd like to introduce the heads of two organizations. We have with us Marcy Yale from AEBC. We have Michelle McQuigg, who's CEO of Balance for Blind Adults. And Robin Dafo, who's chair of the board of Balance for Blind Adults. So please, feel free to jump in and pass your comments as well. There was a comment on the floor here. Somebody?
Yes, I'd like to thank you for this conference. It's been wonderful. I'd particularly like to thank CNIB. I've gotten a lot from CNIB. I've been to both facilities in Toronto several times. Now I'm thinking about the technology issues for vision impaired people. Cell phones came up. There are a number of catch-22s for cell phones. One, obviously, is the cost of the cell phone. Now, CNIB, at one time, I don't know if they're still doing this, had a program where you could bring in your old cell phone and they would check it over and give it to somebody else. One can also buy cell phones a lot cheaper if you buy used phones from many, many outlets. Now, once a person has a cell phone, that's not the end of it. You have to figure out how to use it. If it's an Apple, you can go to an Apple store if there's one nearby. If there isn't, you can tune in to CNIB. CNIB has at least 3 Zoom events per week, how to use your Apple. There's 1 Android event per month, how to use your Android. And you can talk to people who have programs. I've used the latter several times, made some contributions and learned several things. So I'm just pointing out there are a lot of barriers to getting into the tech, but there's also an awful lot of help. available from CNIB. So thanks.
Thank you for that comment. It's Jennifer Urosevic here. I agree. And I think that there's a lot of really good local community. And, you know, one of the points that I wanted to really make is that this is something that we all need to do together. We need to work as a sector to refer to one another. We don't all need to do everything, you know, internally. This is about building partnerships, building relationships, because there is way more work needed than there is for resources that currently exist. And I think one of the things that we've seen with coming together as part of the National Eye Care Strategy is really breaking down some of those silos and looking at what the client's needs are and matching those client needs with the right resources and supports that are out there, depending on where you live in this country.
Okay, so I have a question for you. You brought up earlier with regards to contacting your members of parliament, be it whatever.
Yes.
It'd be nice if the institutions that are involved here would kind of get something started, be it online, in person, whatever, to get signatures and then to send them to whoever, or send out the information on how to contact them and get that rolling so things don't get forgotten and left behind. Also, with regards to technology, yes, CNIB does have a lot of technology, or used to, until all of a sudden some of the people that were employed for technology were let go, and there's only one person, and sometimes he hides from technology. So, you know, you can see things two ways. Anyway, thank you. Bye-bye.
Thank you for that idea. I think that there is a lot of advocacy work that we can do and sharing more information through our social media areas as well. I know that there's lots of organizations in the room and online, and I think that, you know, that's our commitment, is to keep spreading the word and provide those resources. So if you're not already following all of the organizations that Keith has outlined here today, if you use social media, if not, there also is phone calls that you could make to your local offices.
Can I just put in a plug for Balance for Blind Adults? Balance does accessible technology training as well. So.
Hi, good afternoon. My name is Kathleen. I'm a nurse and a volunteer from the Integrated Filipino-Canadian Nurses Association here in Ontario. I have a question. Since 46.3% of the population live below poverty line, is there an organization or an office where these people can access free eye exam, even if it's not related to a medical disease or diagnosis? Because we are all aware that prevention is better than cure, right? Thank you.
Can I
You can
answer
answer that one.
Assuming you're one of the people that have already lost some vision, presumably you're under the care of an ophthalmologist at some stage. For any eye disease, if you go and see an ophthalmologist, those visits are free. So if you have diabetic retinopathy or AMD and you're seeing your ophthalmologist, those visits should be free. It's only the regular eye exams for people who've never had an eye exam before, or people who've never seen an ophthalmologist before, those are not funded. Sorry, Jane.
I'm not sure if there is free clinics. I would say that sometimes if you go on to, and again, I can look into this for you. I can talk with you a little bit afterwards. We do a lot of client navigation and work with people who are looking for some of those resources. I'm not the one, but I know a bunch of people that could probably answer these questions. I'm looking at Sue Marshwoods over there, who seems to know everything that I need to know, particularly in the GTA area. So we can follow up on that one offline.
Okay, I'd like to move on to another question here.
I have a question.
Oh.
I have right here.
Sorry, yeah. Okay, go ahead.
I caught the first thing in your presentation that your survey was conducted in English and in French. The GTA is the most ethnically diverse community probably in the world.
So what are your challenges and how do you look to overcome them to be inclusive of all communities across Ontario?
Thank you. It's a great question. From a service delivery perspective, if a client speaks a different language, we do provide services. So we will hire an interpreter to or translator to participate in the visit. It's really critical, and it's something that we advocate to our provincial governments all the time, that this is an essential. You know, if there is a family member that is their primary support in that area, that may be an area, but you would need to have, you know, proper documentation around that. We want to make sure that the information that's being translated. So we do take that very seriously. This survey was, yes, only done in English and French, but in the clinical work that we do try to match wherever possible, and that we pay for that as part of our services.
Okay, Michelle?
Hi, thanks for this. And my apologies, what I'm doing here is really circling back a little bit to a question that was posed earlier, and just with a quick response, if I may. There was a question earlier about models of mental health integration into service delivery, and I just wanted to flag one example. I know VLR is working on this now, as is Balance for Blind Adults, and our approach has been a little bit different in that we've embedded mental health services into our programming. It is available free to all of our clients. And we've been fortunate enough to have both of our counselors have lived experience of vision loss, which has been really valuable for those who have taken advantage of those services, to have someone with that empathy piece really locked in, and someone who can deeply relate to the struggles that they're going through and offer really concrete solutions. Another approach that we're exploring and that has been effective, I've heard from other organizations, is to implement some mental health focused programming specifically. In our case, that would look like physical recreation groups a lot of the time, but we're also in the process of exploring a therapeutic writing program that might launch later this year. So there are organizations out there with resources on the ground doing this sort of work. And I also just wanted to flag that all of us working together, as Jennifer said, CNIB, Balance, Vision Loss Rehab, yes, we're all different organizations, but we truly are collaborating, and we want to work in the same space and work together to provide services and fill in gaps. For instance, we at Balance recently developed an employment hub that's targeting both job seekers and employment service providers, but this is the kind of resource that we're sharing across the sector, including with some of our partners at Vision Loss Rehab who contributed to that work. So thanks to that, but also just a real emphasis on the need for collaboration at the service level and beyond.
Thank you.
Absolutely. Thanks, Michelle.
Okay, the next question online is which, I think it's sort of been answered, but if you think we've answered it, just tell me. Which 2 to 3 priorities does the panel view as having the highest potential impact in the short term?
Go ahead, Shannon.
I mean, my first thought is mental health. Absolutely, I think that's crucial to taking any step through your journey from diagnosis onward. It needs to be supported. You know, capacity and ability to learn is harder when you're experiencing mental distress. I think there's a duty to support people through this, and I don't see how you can do that without some sort of peer support, integrated mental health, anything that helps them along.
The only other one that I would add really is those referral pathways. We need to, community support services need to be recognized much earlier on in the journey. I think every day I hear from staff that they are seeing clients, that clients say to us, I wish I knew about you earlier. And I'm sure every organization that provides that service hears that same story. We've got to change that narrative. We have to give people choices so that they can make the choice on whether or not they need those additional support services going forward.
Thank you. Next question is, high education but low full-time work, 23.9%. what proven employer strategies should we be pushing? Training incentives, financial incentives, audits? Got any ideas of how the heck do you get employers to employ people?
All of the above. I think that the landscape of employment has changed, and, I think, Keith, you mentioned it earlier, these mandates back to offices are harming, some of those availabilities. There needs to be the right balance. So I think that we have to take a look at truly understanding the value of workplaces and making sure that disability inclusion is not just something on an HR policy, that it is ingrained in the culture of an organization. And again, challenge everybody online and in the room to really think about that in your own organization. And how can we, not make this piece a checkbox, but truly an integrated approach in how we build culture.
I'd just like to add here for the employment piece, and this wasn't, from the survey per se, but from lots of other ongoing and past work, but employers and for industries and for sectors, understanding the role that your industry and your sector technologies play in whether or not someone can work with you is a very, very poorly understood area. And so I think many of us here can either have ourselves or have experienced someone who, either applied for a job or applied for a promotion or connected with an employer, and whatever tools and technologies that are industry specific that employer was using weren't accessible with assistive technologies, because there was never in anyone's mind a notion that someone using magnification or a screen reader or any of these sorts of things would be working on the back end, setting up data architecture, or working as an IT consultant, or even doing data entry as a frontline social worker in a system that isn't set up to let them do those things. And so I don't think that we can deal with employment in this day and age without dealing with some of these things that individual employers can't even address. There's specific vendors and specific opportunities to choose certain products and technologies that their organization will use, but those employers and industries and sectors are that kind of attitude shift that people can and will and are willing to and do already work within these sectors. That's kind of a separate collaborative procurement, accessible development piece that's needed in order for employment to improve.
I've got two more questions. I've looked through here. There are some other questions, but they tend to overlap, and I think we've answered them. There's a question: is there a place to find a list of disability benefits for those of us with vision loss or blindness?
Yes, there is. And I might actually have I'm going to have the microphone go over to my colleague Josie at this table. We were successful in receiving some funding from the federal government, and we've created a program called GAIN, and I always forget what the acronym lasts for. So Josie will explain a little bit about that and how you get a list of. And then we have staff that help to support people with the work. So go ahead, Josie.
Yeah, so we operate a program called GAIN, which is Guiding and Assistance in Navigating Disability Benefits. So we do have disability navigators that can support individuals in understanding what the disability tax credits or other provincial credits or tax benefits that they can receive. We're national, so we do this by province. We do have a page on our website that gives everybody the information. So if you go to our website, you can go to the GAIN page, and it'll tell you exactly how to get referred into the program. Our disability navigators will walk through the process right from the beginning to the end, even if you have to make an appeal. We support getting medical documentation as part of that process. So it's a full end-to-end support for clients.
Well, that answers the next question. Next question was, is the VLRC and CNIB advocating to reduce the time from applying for the CPP disability benefit to being approved. My claim was denied twice before approval. It was a 22-month ordeal. So I guess you've got a system there. Sounds great. So whoever sent that question in, go to Josie's website. And I had one last one, I think. Last question is, eye care professionals drive 46% of referrals. What steps can ensure more consistent, timely ones and reduce regional gaps? I guess, how do you get more eye care professionals to refer?
Yeah, I think we keep doing the work that we're doing. We keep communicating, we keep showing up, we have conversations, we spread the word. I don't know that there's a magic answer to this. We track how many out of, who are registered, and both, I think this one looked at just ophthalmology, but, we get a lot of referrals also from optometrists. And so I think we have to take a look at, individual strategies on how we do this. And again, this is a cross sector. I think it's not just a one size fits all, is that doctors need to know what services are available in their local communities.
I might add that I'm aware that you've been talking to the Canadian Ophthalmology Society about just this issue. So, okay, well, with that, I'd like to thank all of you and all of the people in your organization that collaborated on the study. It's been a privilege to be associated with you. Thank you for doing this. Thanks for doing the study, and thanks for involving me. Thank you.